Hello, today I am showing you the specimen of the cirrhosis of the liver, and before that you have to know the normal surface of the liver. Normal surface is smooth and glistening, and in the case of the cirrhosis it becomes nodular surface. So this is the case of the cirrhosis of the liver, and you can see the outer surface is bumpy. There are so many nodules over the surface of the liver, and after the cut surface, this is cut section, you can see multiple nodules. You can see all these are the variable sized grey brown nodules are there, and in between you can see these are because of the fibrous septa, these nodule formations are there. So this is cut surface, and this is classical presentation of the cirrhosis of the liver. Now depending on the size of this nodules, we have to measure the size. So depending on the size of the nodules, they can be micronodular and the macronodular. So here these nodules are 1 centimeter and few are less than 2 millimeter. So if the size is more than 3 millimeter, they are called macronodular. And if the size of this nodule is less than 3 millimeter, they are called micronodular cirrhosis. And if the varying size is there, then they are called mixed type of the cirrhosis is there. Now what are the defining features of the cirrhosis? When we will call it as a cirrhosis of the liver, first you can learn it by the mnemonic D and B. D for diffuse involvement of the liver, means destruction of the architecture of the entire liver, means any local disturbance. अगर एक छोटे से पर्टिकुलर एरिया में ही कोई नोड्यूल फॉर्मेशन है या छोटे एरिया में कोई डिस्ट्रक्शन है, तब हम उसको सिरोसिस ऑफ लीवर नहीं मानेंगे, मींस लोकल इन्वॉल्वमेंट को नहीं कहेंगे. देयर शुड बी डिफ्यूज इन्वॉल्वमेंट ऑफ द लीवर. सो फर्स्ट डी फॉर डिफ्यूज इन्वॉल्वमेंट, देन एन फॉर नोड्यूलर सरफेस. So multiple nodules should be there. So N for nodule formation and B for bridging fibrosis. These nodules are formed because of the bridging fibrosis. So the third feature is B for bridging fibrosis. For D for diffuse involvement, N for nodule formation and B for bridging fibrosis. Now what is cirrhosis? Cirrhosis is any long-term damage, any long-term injuries or long-term inflammation lead to the cirrhosis of the liver, and finally liver becomes shrunken because more and more fibrosis there, so the liver becomes shrunken. And there are variable etiology of it. The most common is alcoholic cirrhosis. The second one comes the viral cirrhosis. Then because of the nutritional and sometimes metabolic diseases. So all these are the causes of it. Now you can see our museum specimen of the liver. This is outer surface. This is outer surface of the liver. You can see the multiple nodule. Now this is the cut surface. Multiple nodule formation. So this was all about, and the other name of the micronodular cirrhosis is Laennec cirrhosis, Hobner cirrhosis, because Laennec was the scientist and he first introduced the term cirrhosis. So before moving on to the slide of cirrhosis, I will show you the histology of the liver. So just a glance view, this is the slide of the liver, and you can see all the hepatocytes are arranged in a trabecular fashion, and there is a lobular architecture is there. Now moving on to the cirrhosis. So this is case of cirrhosis of the liver. An entire liver parenchyma is converted into the nodular structure. So you can see the nodule. So here one nodule, this is other nodule, this is other nodules, and all these nodules are separated by the fibrous septa. So this is fibrous septa, and all these hepatocytes inside the nodules, all these are the regenerating nodules or regenerating hepatocytes are there, because liver has capacity to regenerate. So sometimes you can see the 2, 3 or more than 4 nucleus inside the hepatocyte. So this is not an abnormal thing.
And the other main thing in the case of cirrhosis, there is a no central vein inside these nodules. So you can see there is a no central vein inside any nodule. This is other nodule. Here also you can see there is a no central vein. So they are devoid of. So they are devoid of central vein. Here this is other nodule and they are devoid of central vein. And these nodules are separated by the fibrous septa. So this is fibrous septa. So under 20x in fibrous septa, you can see the mononuclear inflammatory infiltrate lymphocytes are there. And in hepatocyte, you can say they are still arranged in a cord-like fashion or trabecular fashion. So their trabecular arrangement is still preserved. Why I am focusing on the trabecular arrangement? Because this is lost in hepatocellular adenoma or hepatocellular carcinoma. They can be differential diagnosis for it. Here in this fibrous septa, this is other nodule, this is other nodule. They are separated by these two nodules are separated by the fibrous septa, and in this fibrous septa you can see the proliferation of the bile ductule. So they are the proliferation of the bile ductule is seen in the fibrous septa. So if I am going to this nodule to this nodule, moving on to this nodule, then I can appreciate the fatty changes. You can see the empty spaces. So all these are the fatty changes. So this is high power view of the fatty changes. You can see the fat vacuoles are there. So here in the particular you can see the nucleus is pushed toward the periphery. In the particular this the nucleus is pushed toward the periphery. So if this type of structure is there, we call it as the macrovesicle, and if the nucleus is still inside, then we call it as a microvesicle. And when all these coalesce together, then fat cyst is formed. So all these are the fatty cyst or fat cyst. This is microvesicle because the nucleus is in the center. So inside the hepatocytes, fat accumulated and the fatty changes are there. The important thing is more and more fat we appreciate, that means the lesser the fibrosis is there, because fibrosis is inversely related with the fat inside the liver. If more fat is there, that means fibrosis is less. Lastly, I am showing you the low power. All these are the nodule formations. Nodule formation 1, 2, 3, and all these nodules are separated by the fibrous septa, and inside the fibrous septa there may be the portal triad or the central vein may be there, and the ductular proliferations, you can appreciate the ductular proliferations, bile duct proliferations, and sometimes you can see the mononuclear inflammatory infiltrate. They can be mild to moderate, and there is a no central vein inside the this regenerating nodules. Inside the nodules there is a no central vein. So this is typical slide of the cirrhosis of the liver. I am telling you detail about the cirrhosis. So the defining feature of the cirrhosis are three. They are can be learned by the mnemonic D and B. D for destruction of the architecture of the entire liver. The word entire liver is important, and we can say it is a diffuse involvement. And N for nodule formations. So there is a formation, and for nodule formation, there is a formation of the nodules in the liver, and these nodules they represent the regenerating hepatocyte, as the hepatocyte has intense capacity for the regenerations. So these they form the nodules. And B for bridging fibrosis, these nodules are separated by the bridging fibrosis. They are separated to each other by the bridging fibrosis. Now this is classical lobule, and the classical lobule, it is a hexagonal in the shape, normal lobule. Inside it there is a central vein, and at the periphery there is a portal tract. Here that it's in the portal tract, bile duct, portal vein, and the hepatic artery. On the basis of this, the zonal pattern is there. Zone 1 is near to the portal triad, or we can say near to the hepatic artery. And zone 3 is far away from the hepatic artery. In this diagram, you can see the hepatocyte has a three surface. Number one surface is facing toward the hepatocyte to hepatocyte. The other surface is facing toward the bile canaliculi, and the third surface is facing toward the sinusoids. So this is facing toward the sinusoids, but they are not directly connected with the sinusoids, but there is a space. They are not connected directly with the sinusoids, but there is a space between the sinusoids and the hepatocytes, and this space is called the space of the Descemet. And the space of the Descemet, there is a stellate cells are there, or we can say Ito cells are there. The sinusoids, these are lined by the endothelial cells, and here you can see they are discontinuous endothelial cells. So there can be exchange of the material. So solutes can easily transport it. Now, cirrhosis is anything or any injury or inflammation that causes damage to the liver. This leads to the cirrhosis. And finally, a nodular liver in which delivery of the blood to the hepatocyte is compromised. The classification, morphological classification and etiological classification. On the basis of the morphology, if the size of the nodule is less than 3 millimeter, they are called as a micronodular cirrhosis, and if the size of the nodule is more than 3 millimeter, they are called the macronodular, and when the variable size nodule, micro as well as macro, they are called mixed cirrhosis. On the basis of the etiology, classified as alcoholic cirrhosis, post-necrotic cirrhosis, biliary cirrhosis, cardiac cirrhosis, and likewise. Micronodular cirrhosis is seen in the alcoholic type of the cirrhosis, or is an example of the alcoholic cirrhosis. The important thing is they are uniform size nodules, and they are micronodule because they represent the impaired capacity for the regrowth, as it is seen in the malnutrition or severe anemia and in the old age. So they represent the impaired capacity for the regrowth. Initially, alcoholic cirrhosis is micronodular, but later on, there is a tendency for the nodules to increase in the size. So we can say alcoholic cirrhosis start as a micronodular and they can land up into the macronodular. Now, the best example of the macronodular cirrhosis is post-necrotic type of the cirrhosis. And here the mixed pattern is a kind of the incomplete expression of the macronodular cirrhosis and is seen in the alcoholic type. This is gross picture. Here you can see the micronodules on the surface of the liver. Here this is nodule, cut surface. All these are the nodule and these are the macronodule. Now this is schematic diagram. This is diagram of the alcoholic cirrhosis, and here you can see the uniform size nodule, micronodule. And this is histological diagram. Here you can see the nodule formation is there, and the nodules are separated by the fibrous septa. So they are separated by the fibrous septa. And the fibrous septa, there is ductular proliferation is there. And inside nodule, we can see the fatty changes. As in our slide also, I showed you the fatty changes. And this is spatial stain trichome. And here you can see the nodule formation is there. These are the regenerating hepatocytes. And this is gross picture. Here, apart from the nodule, you can see the greenish tinge. This is because of the cholestasis. Now, pathogenesis, why the cirrhosis is formed? Normally, in the type 1 and type 3 collagens are present in the portal tract and around the central vein. But in the space of the Descemet, the type 4 collagen is there normally. But in the state of the type 4 collagen, when the type 1 and 3 are deposited in the space of the Descemet, creating the fibrous tract. So the type 1 and 3 collagens are deposited in the space of the dizzy, and this is responsible for it. And stellate cells are going to produce this fibrosis by proliferation of these stellate cells and activation of them into the fibrogenic cells. This lead to in these stellate cells convert themselves into the myofibroblast. And what is the source of the activation of these stellate cells? They can be activated by the chronic inflammations or by the cytokines or chemokines or directly by the toxins. So the stellate cells is proliferate and convert them into the myofibroblast and the release of the type 1 and type 3 collagen. So this is silent stellate cells in the space of the dece. And now in this picture, they are going to proliferate. So more and more collagen. So collagen is there now. So this space of disease increase and they are creating a pressure over the sinusoid. As they are creating a pressure of the sinusoid, so there is a back pressure. So this is central vein, this is portal vein, and this is hepatic artery. So there is a back pressure. This lead to the portal hypertension. Now, what does this stellate cells? What does it do? Because of the deposition of the collagen 1 and 3 in the space of the dese, there is a loss of the fenestration in the sinusoidal endothelial cells. As I told you, there is a endothelial cells, they are not continuous, they are discontinuous, so that there is a transportation of the solutes may be there. But when there is a type 1 and type 3 collagens are there, three collagens are there, and there is a proliferation of the stellate cells are there, more and more fibrosis is there. And because of this fibrosis, there is a loss of the fenestrations of these endothelial cells. This lead to the no exchange of the solutes between the sinusoids and the hepatocytes. So metabolic dysfunction is there. And what are the source of proliferation of this stellate cells? These are the certain factors: platelet-derived growth factor, transforming growth factor, matrix metalloproteinases, transforming growth factor beta. They are going to proliferate, help in the proliferation of the stellate cells. Now, what are the clinical feature of the cirrhosis? In general, there's a malaise, fatigue, anorexia, and the weight loss. And the specific feature, because there are certain function of the liver, when they impair, so this will develop the specific feature. Because of the impaired protein synthesis, development of the white nail or leukonokia. Because of the impaired biliary excretion, development of the jaundice and pruritus. Because of the impaired estrogen metabolism, development of the Palmer erythema, testicular atrophy, and gynecomastia. And finally, lastly, the complication of the cirrhosis is portal hypertension because of the back pressure, ascites, development of ascites, varices, bacterial peritonitis, and splenomegaly. Development of the liver failure because of that. Coagulopathy is development of the coagulopathy or pulmonary hypertension. And in 2 to 8% of the cases, hepatocellular carcinoma may be there. Now, as in our slide, there was steatosis. So what is steatosis? It is a fatty liver or fatty changes. They are reversible cell injury. They are showing the reversible changes. And what we see in our slide, they are showing the cytoplasmic vacuoles. So histologically in routine fixed tissue, steatosis is represented by the cytoplasmic vacuoles because fat is dissolved during the processing. When we process our tissue, they dissolve. So they can be visualized by spatial stain like oil red or Sudan black, or if we fix our tissue in osmium tetraoxide. Now, patterns of the distribution of the fat in the hepatocytes can be macrovesicular or microvesical. So in this diagram, I'm showing you the microvesicle. So when the nucleus of the hepatocytes plays in the center, Here again, it is placed in the center, and all these are the cytoplasmic vacuoles. All these are representing, this yellow part is representing the fat. The fat is there, but the nucleus of the hepatocyte is still in the center. They are called as a microvesicular cytosis. And when this cytoplasmic vacuoles or this fat displace this nucleus toward the periphery, this is called as a macrovesicle. Nucleus pushed to the periphery. And sometime all these fat may coalesce together to form the fat cyst. So this is diagram, histological diagram. You can see the here this is microvesicle, here macrovesicle because nucleus is pushed toward the periphery, and here it is a mixed type of the pattern. So this was all about the alcoholic cirrhosis and in short steatosis.